Good morning, everyone. I am Dr. Clifford Deal, President of the Medical Society of Virginia. Welcome to the MSV webinar update on COVID-19 testing in Virginia. It's my pleasure to welcome Dr. Karen Remley, Senior Advisor to COVID-19 testing, response for the Virginia Department of Health, and Dr. Gonzalo Bearman, Chair of Infectious Diseases at VCU. This is the CME blurb that I have to say verbatim. Would like to mention that no commercial support was received for this activity. There were no reported conflicts of interest for any individuals in a position to control the content of the program or speakers presenting. We are recording attendance and will submit this to VCU for CME credit following the webinar. VCU will issue a certificate to you at the email that you registered with. Before we start, I'd like to remind everyone that MSV and its staff has continued to work diligently to pull in all relevant resources on COVID-19 on the website at msv.org/COVID-19. We'll post a recording of this call on the webpage later today, should any of you or your colleagues want to listen in but unable to join us this morning. We have a large number of people on the call, as we've had since this started. And I understand there'll be a number of questions. Please use the chat function on your computer. Those will show up on our computers over on the right-hand side, and we'll try to get to those. I'm going to have to step away during Dr. Remley's presentation, so Dr. Richard Such, last year's president of the MSV, will take over as the moderator. Please keep your questions focused on the topic, on testing. If we don't get to your question or having the topic, please email governmentaffairs@msv.org. With all that being said, please welcome Dr. Karen Remley.
Good morning, everyone. And I'm sorry you're not seeing all of me, but my camera doesn't seem to be working on my computer this morning. I wanted to first say thank you to Cliff and to everybody at MSV, because I feel like we've developed a really great partnership in trying to work through the issues of COVID-19 and how it impacts the clinical community. We have a lot of work to do, and I hear from many of you very frequently, and a great thanks to that. Particularly Sterling Ransom and Sandy Chung have been very helpful and have already volunteered countless hours on subcommittee calls to be able to help us work through issues of testing. You all received, I think, a letter from the commissioner this just yesterday that came out talking about how the health department, which does not have a lab capacity at DCLS to do all the testing in the state, is transitioning over to use those resources for outbreak investigation and point prevalence studies. The commercial labs have the capacity to run those tests, but as I go through some of this information, I want to start off by saying we clearly understand, I understand, and I'm working to make sure everyone at state government level understands that having a lab that has the capacity to run the test is only one part of the work to do to try and get people tested. So I'll start off with the first slide. I said all hands on deck because one of our goals is to test between 2 to 4% of the population. The governor has also stated that means 10,000 tests a day on average. Today we're at 6,600. 2 weeks ago when I started, we were at 2,400. So we're making great progress. But unless everybody who is symptomatic has an opportunity to be tested, we really cannot engage in a full-on containment strategy of boxing in people who have disease, identifying all the contacts, and really being able to control the pandemic. Next slide. I'm sharing with you, these are out on the web, on the VDH website. They are updated every day at 10. And these are just some really, I think, more straightforward ways to look at what's happening in Virginia. As you can see, the number of the total cases by date. We put in a rolling 7-day average, so you can really kind of have more of a sense and smooth out that curve to see where we're heading. As you can see, the number of cases over the last couple of days have remained fairly stable. But remember, we're testing a lot more too, so we're looking a lot more aggressively for cases out in the community. If you were going to go back and look at the beginning of this curve, you'd see that most of these cases were identified in the ER or in the hospitalization setting. And then the second graph is really, and Dr. Bearman can speak to this, is really a classic epidemiology curve where we look not at when you actually got confirmed by the test, but by the time you first developed symptoms. So it's really when did that actual case of illness begin? And as you can see again, that curve and where we're heading. Next slide. We follow as one of the key indicators, and these are indicators used to look at what the disease is doing in our communities, but also to see if we're able to, if the healthcare system is able to handle the disease. So if you look at this one that sort of looks like a calm ocean, the bottom dark blue are beds that are occupied by COVID patients in the hospital systems around the state, beds that are occupied writ large, the total bed capacity, and then the dotted yellow line is when hospitals converted some parts of the hospital into additional beds. That's that surge capacity. We watch that carefully. The good news is we've never in any way come close to exceeding bed capacity in hospitals. The bad news is hospitalizations have remained very constant in spite of all the social distancing work. If you look at the next graph, that is the number of patients hospitalized with a positive or pending COVID-19 test. And again, light blue are people with COVID who are on ventilators. The middle blue is if you're in the ICU, and then total hospitalized patients. And we're starting to see a little bit of a trend in an upward hospitalization. And then the last graph on this page is looking at difficulty acquiring PPE in the next 72 hours. And as you can see, the hospitals now for the last 5 days have not had any difficulty with PPE. I think in particular for a lot of people on this phone, that's an important thing for me to take back to the commissioner, the secretary, and the governor, is we're closely monitoring the hospital, the tertiary care, the hospital settings, but we need to look at the broader healthcare community now and think about what are the metrics we have for that, because there's a lot of shortage, as you all know, of access to PPE in the clinical community, whether it be long-term care facilities, doctors' offices, clinics, federally qualified health centers, and free clinics. Next slide. And then this is another interesting way to look at, the World Health Organization has made the case that we should be trying to have a 10% positive test rate in those that we are testing, to make sure we're guaranteeing that we're testing enough people. And so this is an interesting metric, because you can imagine it depends upon where you're testing. So if we're going to go to a poultry farm in the Eastern Shore where there's an outbreak and you test 500 people, and if 350 of them are infected, your percent positivity rate for that day is going to be much higher. So that's another reason why we have to follow this as a trend and really be thoughtful as we look at it, because it's really a percent of total tests done. And then lastly are the number of people who are tested per lab report, which is just a rough measure of, are we getting enough testing out there? There are additional metrics that will be coming out relatively soon that I'll be using, and that's looking at how many tests are done in per population, per capita in the health districts around the state. So we make sure that we are also geographically looking for disease in all parts of the state. And some of our point prevalence studies will take that into account too. Next slide. So this is a slide that is very, would make a lot of sense to all of you, but I use it to show to, especially to decision makers and stakeholders that are not clinicians, to understand, for them to understand that just measuring a test is actually a 5-step process, not a 1-step process. Importantly, people who are ill need to feel comfortable coming forward and getting that test. They have been given the message for the last 8 weeks that we didn't have enough testing. Now we do have enough testing, but they need to know where to go and how to get there. They need to make sure that they're not going to be penalized if they're sick. There are a number of people who are very worried that they will lose their job or lose their income when they have to quarantine at home for a period of time. And so there are a lot of issues in getting people to actually get tested. Making sure that our clinicians know how to obtain the test. I think Dr. Bearman may talk about this, but the testing, even the PCR testing, is rapidly evolving. It goes from nasopharyngeal to nasal to maybe oral soon to self-administered. And so, and many of them require different media and different types of swabs. So understanding that, having the adequate PPE to be able to get the specimen collection and times that work for everyone, a lab that can take that specimen, and then not just getting a lab result back. This should have probably a double arrow. One goes to the health department. And so for all of you, I think you may know this already, but the labs in Virginia are required by law to report that result. So the health department knows immediately. But then how do you counsel that patient clinically? How do you talk to them about self-isolation? How do you maybe, as their trusted healthcare clinician, talk to them about contact tracing and why it's important that they take part in that, and that it's important for their health, their loved ones' health, and the community. Next slide. So wanted to show you this. This looks a little bit different because I took this from the Virginia Department of Emergency Medicine website early this morning, but VDH has this map also on their website, but it's interactive. So you put in your zip code and it will show you, depending upon what you pick, within 25 miles where all the public testing sites are around you. This just shows them all at once. These can be anything from an ER to an urgent care center, to a doctor's office, to a free clinic, to a federally qualified health center. Anyone who says they're willing to test the public, as you can say, it will tell you over on the side when you click on it, who it is. Like if you look here, Centera Family Medicine at 5th Street Station, it will tell you when they test, how to make an appointment, what insurance, if they take insurance, don't take insurance. If any of you are interested in being a public test site and being listed, please let me know. One of the things that Dr. Chung and I have talked about, and Dr. Ranson, is making yourself a public testing site means you're really working with the state to try and increase testing. And can we somehow work with the commissioner to prioritize PPE and testing kits to those practices? Next site. Oh, and the other thing I would say about that slide is if you are a specialist and you need to identify somewhere to send a patient, if you're not actually doing testing in your office, this is a great way to put in your zip code and then see what are your testing sites around you that you can use. Necessarily, we want to make sure we don't overwhelm emergency departments for just for the purposes of testing. It's safer for the patient and everyone else involved to not have them go to the ER unless they clinically need to be there. Okay, sorry about that. Next slide. And then here, as you can see, this is, and their link is again on the VDH website. This is actually a list of emergency vendors that have already been vetted and approved through the Department of Emergency Management and the Department of General Services. And the emergency vendor list that is updated once a week, it was updated on the 1st, includes all active purveyors of PPE. And it will tell you if they're on the list, they're legitimate, they're real products, and they are actively able to bring them, bring product in and out. So for any of you that are looking for access to PPE, this is a list that might help you identify places you could go. There is PPE, a small amount, that goes out to every health region and then is distributed to local health departments, and they have a priority list to distribute that PPE as needed. Long-term care facilities right now, as you know, there are many outbreaks, are at the top of that list, trying to get some PPE to them as a bridge. I'm working hard to try and have free clinics, federally qualified health centers, and primary care doctors added to that list. But again, that is dependent upon how much comes into the state and then how much is able to be pushed out. So it's not a smooth, regular pipeline. Next slide. And we're just going to watch the first minute of this. This was a very quickly done video, and to show, for you to maybe show your employees about how to obtain a COVID-19 test. It's 8 minutes long, but we'll just watch the first minute to give you an idea, and then we'll have the link up again on the MSV website and VDH. I'm not sure we're hearing sound.
Taylor, you may be on mute.
I think you have to be sharing your computer sound.
So if it doesn't work, I can talk over this, but essentially, as you can see, there's a narrator who's explaining how you can stand 6 feet away, have the patient obtain the swab. It goes through what to set up ahead of time, how to watch them take the test, how to tell them how to put the test into the vial, and how to put that into the bag, It explains how the patient should wash their hands and then leave, and then what you as a provider do. So it gives a good doff and don, you know, how to put on your PPE, how to take it off, what the patient does. And we're going to be doing these also for long-term care facilities, and to just really be able to give an opportunity for you to be able to help instruct your staff to be more comfortable with providing testing in your offices. And then the second video, because I think we could go on, it's okay. The second video is actually Dr. Baccaretti, who's the patient in this video, is talking to a patient, and it's just a suggestion for a script about how you share positive results for them, talk about clinically following them and observing them, and then also introducing them to the concept of contact tracing, and how you as a trusted healthcare professional are going to kind of do that warm handoff for them to say, the health department will be calling you, they'll be talking to you about contact tracing, this is an important and good thing for you to do. And we'll share these links. You know, technology some days works and some days doesn't, so we're all good. With that, I think I'll, Richard, do you want to turn over to Dr. Bearman, and then we'll get questions later?
Sure, I can do that. Thank you very much, Dr. Remley. And Cliff is still on, but as he said, he's going to have to go to the OR. So thank you, Cliff, for starting all of this. Now we'd like to go to Dr. Gonzalo Bearman from VCU.
Good morning, everyone. Thank you for joining me today. It's an honor to be here with all of you. So what I'm going to cover in the next handful of slides is a COVID-19 really an update on testing from the VCU perspective, having a little bit of relevance also with the global process that's going on. So if we could go to the next slide, that'd be great. Great, I feel it important that I have my disclosures. I do have prior research grants from Pfizer, BioVisual, Vestigen, Cardinal Healthcare, Molnick Healthcare, and AO Orthopedic Foundation grants, none of which are relevant to this discussion. Next slide, please. Okay, so in brief, what are the commercially available tests for SARS-CoV-2? Well, there's really two ways to categorize or break this down. It's viral detection and serology. On the viral detection variety, it's the molecular PCR is the one that's most commonly used. And the examples include Roche, Abbott, Cepheid, BioFire, Becton Dickinson, and Thermo Fisher. We have Roche and Cepheid here at VCU Health, and we also have our own internal PCR-based test, which we use aggressively, and I'll tell you about that shortly. With respect to performance, the sensitivity is generally very high, and the specificity is also very high. That's provided the samples collected properly. Dr. Remley gave an example of really alluded first to the nasopharyngeal sample, which really was or is the way to get a test sample done. The other is the nasal swab, which is certainly much less invasive, much easier for the patient. I don't know if anyone on this call has had a nasopharyngeal swab done before. It's not particularly a pleasant experience. Feels kind of like a quick brain biopsy. At least that lasts only a second. So going from the nasopharyngeal swab to the nasal is probably going to be a huge boost forward. The salivary test, which seems to be around the corner, could be a game changer for us. We'll see how that plays out. Okay. So those are the viral detection side. On the serology side, it's really not something that we're using really much at all here at VCU Health, or it's really of much value for diagnostics for the acute in the acute setting, but it may be of value if you can do it a point of care as a finger stick. The examples numerous are being developed. The performance, unfortunately, is unproven and highly variable. So it's something that's potentially promising, but not here yet. And high throughput serology is available through Abbott and Roche and Diacerin. The performance is also very high and the specificity is very high. However, I need to underscore this is not used for acute diagnosis. This is probably better for surveillance, research, public health, epidemiology, et cetera. So let's move on to the next slide, please. So what's the value of diagnosis of COVID-19? And I want to really focus on two things, symptomatic, and I'm actually going to branch into asymptomatic patients also in the course of the next couple of minutes. So next slide. And to kind of frame the discussion, I like to quote from a book that I read years ago when I was studying public health, the Master in Public Health degree, and I really found it quite enlightening. It's called Betrayal of Trust by Laurie Garrett, and it talks about the collapse of global public health. In that, she argues that public health is an essential trust between government and its people in pursuit of health for all. This includes a healthcare system that follows a primary maxim of medicine, which is do no harm. Really, what I would argue here is the goal here with respect to COVID-19 testing is to maximize safety by identifying asymptomatic and pre-symptomatic patients upon entry into the healthcare system, in addition to identifying those that are, or confirming those that are ill, so the appropriate isolation and treatments are started. Let's go to the next slide, please. So what's the value of COVID-19 testing? Well, for symptomatic, even if it's mild in outpatients, social isolation, contact tracing, and of course surveillance data, but this would drive policy and healthcare approaches. For the asymptomatic cohorts, whether it's inpatient or outpatient, it's important for diagnosis, isolation, and contact tracing. It also guides the use of personal protective equipment, particularly in the inpatient setting, the operating rooms, and the procedure settings. In the event that an asymptomatic patient is positive pre-procedure, it serves to delay or postpone non-emergency procedures and may provide an element of fear mitigation as a strategy. That, of course, is much more difficult to quantify. Let's move to the next slide, please. So what's the biggest problem with containment? Well, there's two things here. There's delay between exposure and showing symptoms. There's transmission from asymptomatic hosts. So let's talk about that in a little bit greater granularity. Move on. Go to the next slide. So he's here to remind us that transmission is really through respiratory droplets among close contacts. I think everyone here on the call is aware of that, but it's also important to say that these droplets are exhaled in the absence of severe symptoms. And that's really where things are very challenging from us from an infection prevention, epidemiology, and public health containment strategy. So next slide, please. We can just go click through to the next if you don't mind. Excellent. So this is the first report really of transmission from an asymptomatic person. This is the case that happened in Germany with an index patient, I believe was a Chinese national and visited Germany, attended multiple business meetings, it was asymptomatic, then took a flight to China, symptoms manifested after the flight to China. But you can see during the course of the business meetings, patients 1, patient 2, patient 3, and patient 4 had an element of contact amongst each other with this index patient and then ultimately developed symptoms and were confirmed PCR positive for COVID-19. Really the first example of asymptomatic transmission. Next slide. The other example that I want to highlight is the transmission of the Diamond Princess cruise ship. As we all know, or we've heard, there were over 3,700 passengers, of whom 634 had confirmed SARS-CoV infection. From the modeling data that was published, it was estimated that the estimated proportion of 18 to 40% were asymptomatic at that time. Of the 556 Japanese nationals evacuated from Wuhan, all tested by PCR for SARS-CoV-2 and followed for 14 days, there was an asymptomatic proportion of 20%. So really something that's not trivial. Next slide. And what we've learned from China is that of the cases, 81% reported mild symptoms, 13% reported severe symptoms, and 4% were critically ill. So there was a significant proportion of patients that had mild symptoms and were even asymptomatic prior to diagnosis. Let's go to the next slide. So to summarize the COVID-19 disease course, in the first 5 days or so, which is the median time for an incubation period, symptoms are obviously absent, but there is increasing viremia, as you can see in this slide. By the time acute, a mild phase is present, there's significant viremia, and that's usually when, or typically when the diagnosis is made through nasopharyngeal screening. And then of course it can go on to the inflammatory ARDS phase and then recovery. So let's move on to the next slide. So with all that in mind, what's the VCU Health COVID-19 testing experience to date? So let's go to the next slide. I think this next graphic will give us a pretty decent understanding of how things went. I want to rewind all the way back to early March. I believe it's March 2nd. That's so long ago, it seems, this saga of COVID-19, where testing was woefully inadequate and difficult in the Commonwealth of Virginia. At that time, I believe there were 30 tests available per day for the entire Commonwealth that was coordinated via the DCLS lab. So essentially what the Infectious Disease Service was doing here at VCU as part of the Greater Command Center response was screening calls from frontline providers to be the gatekeepers to the gatekeepers, and we had to go to through an entire process of checklists and exposure and travel, et cetera, to approve a test internally, which would then be called into DCLS for their approval, and they ultimately had the final say, and testing would happen, and anywhere between 18 to 24 hours later, you actually had a result. So as you can see, our numbers were very low, and they've been incrementally increasing over the course of the last several weeks to months. And that is because there's been expansion of testing, of course, through the state, and also expansion of testing internally here at VCU, where we now have a PCR that's in-house. On any given day now, we can test up to 500 people just at VCU Health for COVID-19. What you see here is the number of people tested overall in the bar graphs. The red are the number of positives, and our positivity rate is not quite at the 10% as alluded to by Dr. Remley. It's actually around 14 to 15, sometimes as high as 17%. Again, suggesting we're probably not testing enough people. Next slide, please. So here's our experience from April 30th to May 6th. For hospital admissions, we did a total of 1,500 tests. Positive at that time was 116 or 7.7%. Presumptive positive were 5 or 0.3%, and we had some inconclusive. The next thing I want to mention is actually quite interesting. It reads PACE tests. PACE tests are our outpatient pre-surgery clinic, and this is for people who are coming in for elective procedures or surgeries. We started this over the course of the last several weeks. We've only done a couple hundred tests to date, slightly over 200 as of now. But essentially what we're trying to do is screen patients prior to an invasive procedure to minimize the risk of contagion not only to the hospital, but also to minimize their potential adverse outcomes for undergoing a surgery and then manifesting SARS-CoV-2 or COVID-19. Of the couple hundred that we've tested so far, we've found none positive. It may be low yield, but it's certainly what we're doing in the beginning as we open up the healthcare system to elective procedures. Next slide. I also want to share this with you, and I think this is really interesting. This is a letter or memo that came out internally. I've truncated it, but the bottom line is that we now do pre-procedure COVID-19 testing in drive-through sites. What do I mean by that? Well, the drive-through site is right here across the street, actually on top of the parking pavilion, and one can get a for one who is undergoing a procedure or some sort of elective surgery, you can be assigned a time at the drive-through site, referred by your doctor or your surgeon to have the pre-procedure testing done through a nasopharyngeal swab, transitioning actually to a nasal swab, so making it less invasive and really increasing or ramping up our ability to test our patients as they come into the hospital asymptomatically. Next slide, please. So I want to wrap this up by introducing this gentleman who I quote a lot in the course of my lectures. So those that have heard me before, I apologize for repeating this. It's called the Satisfice Approach. And here I present Professor Herbert Simon, who won the Nobel Prize, I believe it was in 1974. He was actually an economist, not a physician or a scientist. But he's coined the term Satisfice, which is a combination of satisfy and suffice. In his Nobel Prize speech, he urged decision makers to either satisfice by finding optimum solutions for a simplified world, or by finding satisfactory solutions for a more realistic world. I raise this because we're trying to find satisfactory solutions to the realistic world of COVID-19 here at VCU Medical Center, attempting to increase our reach across not only our inpatient population, the emergency department, but also asymptomatic patients coming into the hospital. In addition, we're also partnering with the Department of Corrections and neighboring or surrounding long-term care facilities to expand their ability to test patients. So next slide, please. So the bottom line is at present, there's no perfect real-world COVID-19 testing strategy, but our overarching theme is to try to expand it as much as possible and as democratically as possible. Next slide. I always have to acknowledge those around me. Dr. Chris Dorn from the microbiology lab, Dr. Emily Godbout, pediatric infectious disease epidemiologist, Rachel Pryor, my research coordinator, of course, the VCU Hospital Infection Prevention Program, who does all the work, so I can take most of the credit. And of course, Peggy Andrews from VCU Infectious Diseases, who helps me with all of my academic administrative coordinative work. Thank you very much.
Thank you very much, Dr. Bearman. That was an excellent presentation. And thank you for acknowledging those who work with you. I think all of us know that this is a team approach and none of us can do it on our own. And that's why we're having these webinars to keep our membership informed and to make sure that we're all working together off of the same sheet of music. We do have some questions here. I think that this one perhaps for Dr. Bearman, You mentioned nasopharyngeal samples and also nasal swabs. There was a question here from Dr. Bhushan Pandya asking, what is the difference between an oropharyngeal and nasopharyngeal specimen collection? And I think he may mean nasopharyngeal and nasal, because he says then nasopharyngeal swabs are not available. And we realize that this has been a problem, the availability of the nasopharyngeal swabs. So can you explain the difference between the various specimen collection?
So in terms of the specimen collections, the nasopharyngeal is essentially the tube, the little wand that's inserted not only in the nose, but all the way back to the pharynx, and it's very uncomfortable. That's usually done on both nares to increase the diagnostic yield. The nasal swab is really much more in the interior nares, as one would do, for example, for a Staphylococcus aureus or MRSA screening. Is much less invasive to the patient and much more comfortable. The results or the performance of the tests are believed now to be equivalent. So if we can transition to nasal, all the better. As you know, it's always a scarcity of actually testing materials and supplies. And I believe the nasal is not quite as available as of now. There is hope that there's going to be an oral, basically salivary sample that one can submit that's in development. I know that VC wants to test and validate that hopefully in the next week or so. That would make things even easier for us.
Okay, thank you.
And Richard?
Yeah.
Richard, this is Karen. Just to add, both LabCorp and Quest will put together.
I just lost your sound, Dr. Remley.
Everybody there? Can you hear me?
You are now.
Okay, sorry. I was going to say we've been talking with LabCorp and Quest, and they will send out testing kits that include the swab, everything in a kind of one-shop stop. There's a limit to how much they'll send to any one provider. But again, if people are interested in becoming a public testing site or testing, in their community, shoot me an email and I'll add you to the list. Because as those, LabCorp, as you can imagine, both of those organizations are national in scope, so they kind of distribute across the nation. But we also have, and we'll have soon, a website for all the labs that we've already vetted, that are FDA and CLIA approved, that you could also use. And we're exploring the opportunity of, working with them to give them, here's a list of primary care providers who we've identified because of geographic location or interest in testing that we want to have be part of the system, and we'll try and connect you up with them so you can get the whole kit. And once you've gotten that, it really decreases the issues of having medium but no swabs and vice versa that become an issue in much larger organizations.
Thank you. That'll be helpful, I'm sure, to a lot of people, and hopefully they'll step forward and join you. Dr. Remley, we do have a question here that was addressed to you, but again, either of you can chime in on these. Dr. Remley, our planning health district does not have baseline prevalence information, either for the medical care community or the population at large. How can we then safely reopen in this situation?
And that is exactly why the health department is transitioning, because there's enough, there's 1,470 tests per week now available through UVA, VCU, Virginia Tech, and the GCLS. So there's the ability to do point prevalence testing, and that's being done across the state right now. I think this has always been an issue of a rapidly moving target of trying to take care of patients in the hospital when we have very little testing and not a lot of PPE, and wanting to provide really high quality care. I'm always very proud to say, as a Virginia physician, although people talked a lot about crisis standards of care, patients received quality care and continue to across the Commonwealth. The next big goal, besides responding to those outbreaks in long-term care facilities, in prisons, in plants, which we're going to continue to do, is to do that point prevalence testing. So there will be point prevalence tests being done in every district. So we get that background information. In addition, they're going to do point prevalence testing in specific vulnerable populations and communities to understand what the point prevalence is there. And then lastly, some of you maybe remember Dr. David Trump. He was a local health director and was the state epidemiologist for a period of time. He'll be working with the hospital systems to do a point prevalence serology testing. testing 5,000 individuals around the state to see if we can gain information from that. And that'll be starting up in May, working with the hospitals, and hopefully we'll have those results by the end of June. And the good news, I think the other thing I'd add that Gonzalo said, which is true, across the state, hospitals are doing pre-op procedure testing, which will also give us a lot of prevalence detail as we look at those, because that's mainly an asymptomatic population. Totally anecdotally, what we've learned, Centera was telling us that they, like VCU, had not found any disease in asymptomatic people going in for surgery or procedures, but they have found it in patients who were coming in for other medical reasons that were not identified as having COVID symptoms. So an interesting kind of flip in what they were seeing.
Thank you. Go ahead, Dr. Bearman.
Yes, so I'm sorry to interrupt there, sir. So if I may add to that, we are not seeing any, obviously, pre-op patients with a positive COVID test, but we are seeing some asymptomatic screens on admission coming up positive. Like, for example, I think there was a pregnant woman. I believe also there was an acute appendicitis that had been going to the OR. So it's uncanny what we found. It was actually quite interesting. We hope to be able to add to the surveillance data of the Commonwealth of Virginia by carrying on with this kind of testing.
So there have been two very encouraging things here. One is the graph that showed that there is availability of adequate PPE. And the other is that we are increasing our testing because of the increased availability of tests through commercial labs and places like VCU. One question that I have had is that in the federal guidelines, I'm not exactly sure how they jibe with the state guidelines. Reopening was tied to a 14-day decrease in the number of cases or a 14-day decrease in the percentage of positive cases. And to me, those two things are very, very different, because as we test more and more people, we're going to see a decrease in the percentage of positive cases. And in fact, on a recent BDH webinar, we saw that there was a 4 to 5 day decrease in the percentage of positive cases. But having said that, the number of cases identified has not been decreasing. So which of those two measures are we using to determine when things will reopen?
Both. And I think you've just hit on the incredible complexity of an evolving pandemic and people wanting to have very specific measures that, you know, the door opens or closes. And I think you probably have all heard many people describing this as not we flip the switch on and everybody goes back to business as usual again. Because if we did that, we just, you know, end up with another big peak surge. But is it more like a dimmer switch where we're still doing social distancing, we're still wearing masks, we're still aggressively hand washing, we're still doing point prevalence surveys, we're still very actively screening the community, but loosening up a little bit? Because, and these are metrics that, you know, through modeling, through the best that epidemiologists know, you know, we've used the UVA model combined with many other models to look at these to see what's best. But you brought up, you know, the percent positive testing and how many cases we see are very dependent upon how much we test and people's willingness to be tested, which is something that is now becoming an issue. You know, especially the example I will use is the Eastern Shore right now, where a number of very, very low wage employees work in poultry plants. And if they are asymptomatic or have very mild symptoms, they do not want to be tested because they want to be able to continue to work. And so, you know, I think we're going to be dealing with a increasingly more complex effort as we look at this.
Yeah. So at the beginning, we were testing only people with extremely high positive probability of positivity because we were so restrictive. Now we're testing a lot of people coming in for surgery or for other things with low pretest probability. So the percentage of positive tests is obviously going to decline. There is a question here that's a very practical question from Dr. Buettner. What is the cost for the patient when I send them for testing if I'm not able to do it in my office?
The cost of the test is $102 is the Medicare rate. Every insurer in Virginia covers that test cost along with Medicare and Medicaid. There is an HHS portal that if you are testing an uninsured person, you can go in and it will be reimbursed. and you do not have to be a U.S. citizen to have that be reimbursed. So the federal government has tried to make sure that everybody will be able to have access to a test without a charge. I think the thing I always tell people to be careful of is, depending upon where you go to get tested, if you also have a clinical visit, then there may be a copay or whatever your insurance, has associated with that visit. And there have been a little bit of people being a little fraudulent in that area, charging a handling fee, which is not supposed to be charged in addition to the test. So, I would, again, the public testing sites that you see on the BDH website have all been vetted to make sure that they're, honest brokers.
Okay. Another question that came in is a very specific question. This individual watched 2 webinars this week, one on IBD and one on cirrhosis. Both did COVID updates and recommended nasal swab testing for any IBD flare or elevated liver enzyme, respectively. And I guess Dr. Gonzalez, this person said, does the ID doc agree? Or either of you?
Well, I guess since you referred to me first, I would say I don't think it's unreasonable to get tested, particularly as we have a very low threshold now. I can't give a data-driven answer with respect to how COVID-19 impacts either on chronic liver disease or inflammatory bowel disease, but it is known to kick off an inflammatory cascade, which certainly could exacerbate those conditions, so it's not unreasonable.
And I would agree from a public health perspective. There are the public health recommendations of who to test for public health, but at the end of those, it says, and any test that a clinician deems reasonable. And every day we're learning something new about COVID. So I think, again, that's to give, to make every clinician feel empowered that if they say, there's a reason to potentially test for COVID to gain more data, to understand better the clinical course, it certainly makes sense.
Okay. Another question here. Could you comment on testing of patients and staff in skilled nursing rehab residential facilities? Is Virginia mandating systematic testing once COVID is identified in a setting, or are they just relying on the facility to do it or to request it?
So we have a goal to do point prevalence testing in every single long-term care facility in the state. If they, you have to be invited in. If there's an outbreak, the public health law says, yes, the public health can go in and can do an outbreak investigation. If you're doing point prevalence to just see if there is disease in that institution, we partner with them to do that. As you can imagine, the point prevalence, you have to work with the long-term care facility, nursing home, to make sure that they understand what they're going to do with the test results when they get them. There are frequently, even in nursing homes, asymptomatic patients. There are asymptomatic staff. Many nursing homes are very short-staffed. So if you identify a number of their employees that are infected and they have to go home to be in isolation, it can really result in difficulties very quickly in terms of staffing. We've worked with our Medical Reserve Corps volunteers to try and bridge that. A number of the health systems, including VCU, have been very supportive of trying to help with staffing as we work through how do we approach it in these nursing homes and long-term care facilities. It's very difficult because as they go into the hospital for acute care and then need to go back to the nursing home, and I'm sure Dr. Bearman could speak to this, being able to make that transition back again can at times be very difficult. And I don't think we know, maybe Gonzalo, you want to talk about viral shedding and how long a test can be positive? Because I think there's a lot of confusion about clearing people to go back to a nursing home or long-term care facility.
Right, so there is confusion, and the viral clearing has an interesting dynamics. For example, one can be over the clinical disease of COVID-19, but yet still have viral clearance for a handful of days or even up to a week after resolution of symptoms. We've seen some reports of viral clearing going up to 14, even 14 plus days absent symptoms. So what we've been employing here at VCU for transfer out to long-term care facilities is that we do 2 negative viral PCR swabs, nasopharyngeal, 24 hours apart, to really confirm that the resolution of viral shedding, to really mitigate the risk of transmission to high-risk populations, particularly in a community setting such as long-term care. It's not foolproof, though.
A question came in from Russell Libby. It's kind of a long question. Let me try to summarize it here. He talks about a problem keeping qualified lab techs wanting to do the tests and out of quarantine because of their fear of exposure. He says most have been able to get PPE, but some are unsure whether it's really adequate PPE because there have been all the problems with some PPE that wasn't protective. And there are questions about donning it properly. Are there training programs to help expand testing technician numbers?
Yes, we are working with the National Guard. The Virginia National Guard is not only helping with point prevalence testing, outbreak testing, but they also have teams that can come in. If any of you have an interest in your group, to have them come in and teach how to use protective PPE, what's appropriate. They're very well trained, very good. You know, they've trained for bioterrorism and biowars, and so they're very professional. They can come in uniform, not in uniform, and do that training.
Someone says here, we are currently recommending masks, but doesn't it make sense to use face shields in place of or in addition to a mask to protect ourselves? So I guess it's the question about what PPE is needed, particularly if the patient is self-testing as opposed to you testing them.
So you didn't get to see the video, but if you were able to watch the video, you'd notice that he has a surgical mask on. What's recommended for self-administered healthcare observed testing is goggles or a face shield, a surgical mask, and either a lab coat or gown and gloves. And yes, I think face shields are easier for people to wear because it's easier to breathe and move around.
If I may add to that, we are also recommending face shield use here at VCU on top of either a droplet mask or PFR N95 mask for two reasons. One, it allows for extended use of that mask for longer periods of time during the course of the day, minimizing contamination of the mask. It also in many ways almost functions like as the human version of a dog cone, which essentially prevents the healthcare worker from touching his or her mouth, eyes, mucous membranes at the point of care and potentially self-inoculating.
Dr. Remley, you talked about, and Dr. Bearman, about the increased availability of testing. Someone here says, in general, what is the testing capacity and accessibility looking like specifically in the more rural southwestern parts of Virginia?
So from a public health perspective, it's that public health team who's partnering with safety net providers to provide testing, and hospitals. We do know that hospitals across the state, with the leadership of UVA and VCU and Virginia Tech, and our commercial labs, are now able to get their tests back within 24 hours. Many have the rapid turnaround, so they can literally within 45 minutes know the results of point of care testing. For both LabCorp and Quest, they say it's 24 hours for inpatients and 48 to 72 hours for outpatients. And they've been pretty consistent about that for the last 2 weeks. There is plenty of capacity in labs to run the tests now. Every day I get a new lab email that says, we're up and running and we would like to do work for you here in Virginia. I think the hard part here is connecting up providers with the knowledge of how to collect the test with the PPE, with the testing kits to be able to get that done. So the first thing I'd encourage you to do is, if you work with, if you do labs in your office and you've routinely used one company, to call them and say, I'm testing for COVID-19, I would like kits, and get them mailed to you. And then you can use your routine way of doing that. If you have no access to PPE and you're a primary care provider, email me or MSB and we'll add you to the list and see what we can do as PPE becomes available in sporadic ways in the state. I think that some health systems will be creative in trying to make sure that, especially if they know their safety net clinics and their large PCP clinics, to try and help them with PPE so the testing occurs outside of the hospital, so you're not bringing a lot of potentially infected patients in. And so, there will continue to be use of the public health labs to do those point prevalence surveys and to be able to do outbreak investigations, but the capacity is not enough to essentially test the whole state. And our goal is to try and make sure that people can do COVID testing the closest to how they do testing for other diseases.
Thanks. There's a question here about not PPE for healthcare workers, but the general population. Someone said, what are the recommendations for the general population who want to avoid the virus for using face shields and masks?
Well, I would say, if I may, because I get asked this quite often, is the general public generally does not require medical grade personal protective equipment, such as droplet level or surgical masks, or even PFR N95 masks, which we know one has to be fit tested for that mask to wear it properly. So the cloth mask is the default for really much of the general public. The cloth masks probably have some benefit. They're not as good as a medical mask. They're probably good for source control. So someone who's symptomatic or mildly symptomatic, at least minimizing their droplets to others. So it's not only an act of protecting yourself, but maybe protecting others by wearing it. In terms of wearing face shields in public, don't think that's necessary. Maybe Dr. Remley has a different opinion on that. I still have to say that tried and true hand hygiene never hurts also.
Yeah, and I would say the same thing. I think, we've been able to, starting to get more and more research about how communities that wear masks, but also have the culture of social distancing. So I think the hard thing with masks is I sometimes see people that as soon as they put on their cloth mask, they think I can now be within a foot, we can now all be close together again. And we need to understand it's only one tool in the tool of social distancing. And so 6 feet apart, not shaking hands, hand washing frequently, hand sanitizer are all part of the solution. I do think when you're in an environment where people have on masks, it's also a clue to do social distancing, where I think that's an important part of what we're going to have to do. And I think I would encourage everybody, the health department is working very closely with commerce and trade, and there's a large task force that's working with the governor that includes businesses from all over the state, very small and very big, to think about how do you use social distancing principles as you start to try and think about slowly but surely dialing up that dimmer switch a little bit. And these are all works in progress, because there is no playbook somewhere that says this is the way to do this, and to have us do it right. So you as leaders in your community, being able to articulate that, asking people to be patient, having people understand that the severity of this disease when people do become very ill. I think sadly, we've not put enough of the faces of the people who have been severely impacted and passed away from this disease out there for people to understand why it's really important that we do the things we're doing.
Thank you. There's a question here. If I test widely in my office to increase the percentage of testing and turn up even one positive test, have I just shut down my office?
Gonzalo, you want to, that's an infection control.
At the beginning, people were afraid to open their offices because they'd be out of business for 14 days. Yeah.
We're definitely not shutting down offices here for any of that. We're still using standard cleaning procedures for essentially the outpatient environment or the enterprise. We are in the inpatient setting for COVID-19 positive rooms, where obviously there's been more intensive care, aerosolization, aerosol generating procedures being done. We are employing the TruD robot for terminal disinfection. That is not necessary in an outpatient setting. I would use whatever standard cleaning process you have available for that.
And using PPE in your office, if you're seeing people that you think have COVID, it will prevent you from being exposed. So there's no reason, your healthcare workers, if they're using appropriate PPE, you don't have to worry about them being exposed.
That is correct. We would expect that all healthcare workers, patient-facing, having direct patient care, should have the appropriate personal protective equipment on at this time.
Is VDH monitoring sanitizer availability? We're finding problems locally, and our provider just went out of business.
I'm sorry, could you say that again? I got half of it.
I'm sorry. Is VDH monitoring sanitizer availability? We are finding problems locally, and our provider for hand sanitizers just went out of business.
So the Department of General Services and VDEM, Virginia Department of Emergency Management, that's on that web link that I gave. You can look up and see, I think hand sanitizers are included in that list. It's all kinds of PPE. So it'll help you find reputable companies.
Okay. And in regard to that, Dr. Remley, someone also asked about the map of testing sites. And so I think you provided that or can provide it. We will make sure that some of the things that have been asked in the questions here, the resources and the information is available on the MSV website.
Absolutely. And then I think Lauren and I are talking, or the MSV team after this, thinking about how we can make a very physician user-friendly website, both on the VDH website, but for you all that would link directly. The other thing I didn't talk about is starting, I think it's the end of next week, but don't quote me on that exact date, we will be using a forward-looking triage tool, which is essentially an app on your phone. The state of Massachusetts is using it, and a patient can anonymously enter their information. It follows the CDC protocol, determine if they're low risk, medium risk, or high risk for COVID, and then it refers you to your doctor. You know, if you're medium risk, call your doctor. We'll be able to link up if that doctor is on telemedicine. Would you like to have a telemedicine visit with your doctor? It will also say, if your doctor has determined that you should get a COVID test, they can link to where those public testing sites are. And then obviously if you're high risk, it's, go call 911 or go to the emergency department. I think that app will be good for patients, but also good for doctors to be able to have their patients enter that information, because then they receive a text message if they request throughout their days of quarantine to remind them to self-isolate, but also to touch base and see how they're doing clinically.
A question, very specific question here about pre-procedure testing. There's mixed information about whether all pre-procedure patients for EGD colonoscopy should be tested. Do you have an opinion?
So my opinion, which is essentially the VCU party line, is that we are testing for pre-procedures such as EGD, colonoscopy, any invasive procedure like that is being tested. Now, the question that I wasn't asked, which I'm just going to go ahead and answer because I think it's out there all the time, is, well, how long does that test negativity result last? So if someone is tested negative on Monday, when is it okay for them to go for the procedure? Friday? Next week? What we can tell you is our response is as follows, and this is based basically on a consensus of epidemiologists around the country with no real data, saying that if you get a test done, it only tells you, assuming it was appropriately collected the sample, that the test was negative on that date, is probably good for 24 to 48 hours. So we encourage or strongly recommend that the procedure take place within 24 to 48, up to 72 hours maximum. After that, that negative test essentially goes out the window.
We had several questions about sensitivity and specificity of the tests. So this one sort of summarizes it, I think. Dr. Bearman said the PCR test is highly sensitive and specific. The sensitivity piece seems contrary to what I've been reading and hearing on other webinars. Can you elaborate on that? Does it have to do with the fact that there's a lot of outpatient swabbing for sampling? Why is it so hard to get swabs? Well, that's multiple questions, but I think the question was, what about the sensitivity and specificity of the tests?
So we are confident that the sensitivity and specificity is high using nucleic acid amplification if a proper sample is collected. So that's bilateral nasopharyngeal sampling that we're doing. And we feel it's north of 90 to 95%, which is a reasonable standard and has been reproduced across various labs.
And I would just add, in terms of swabs, again, if you're not using kits or don't have access and you don't have swabs, let me know, because we're going to get in, I think, over 200,000 swabs from the federal government. But again, we don't know what kind yet and which PCR tests, what kinds of swab they are to be able to tell you whether you'll be able to use them or not. But we'll certainly let MSV know as soon as we know and come up with ways to distribute some of those. I mean, that's been one of the hard things, if you don't know what Christmas gift you're getting until it in a couple days of coming, it shows up, and we don't always have the same combination of swabs and kits or PPE that make it all go together.
And the only thing I would add to my comment is that the sensitivity also increases with increasing severity of symptoms. So there was a slide I had that showed the progress of disease incubation, mild symptoms, more aggressive symptoms, and the viral load or the viral PCR status. Clearly, the viral shedding is less in the asymptomatic phase. So if we're testing more in the asymptomatic phase, they will have less reliability of the test compared to testing more during the symptomatic phase of the illness, where a negative test, given a proper sample collection, is probably a negative test.
Okay. I think I'm going to make this the last question because we're almost out of time. During a routine clinic visit with a non-COVID symptomatic patient, what should the staff be wearing? I guess that goes to, should you be doing sort of universal precautions, or do you need a mask if you're seeing someone that you don't think has COVID?
Well, I will relay the VCU party line here. So we use universal precautions or standard precautions, as does everyone else. But in addition, for all our patient-facing personnel, at the very least, they should be wearing a cloth mask. However, it's recommended that they wear a medical-grade mask. This is for universal care, non-COVID, suspected non-COVID, or someone not requiring isolation precautions for other infectious diseases.
Okay, thank you very much, Dr. Remley and Dr. Bearman. This has been very, very informative, and we had lots of questions coming in, so thank you to all of you who have been participating. I think I managed to get to many, if not most of them. Thanks again for joining us, and as Cliff said at the beginning, this webinar will be posted on the MSV website, so if you have colleagues or others who were unable to be here at 8 o'clock this morning, they can view it, and we will try to collect some of this information, as Dr. Remley said, perhaps putting out a little FAQ document for your reference. So thank you very much, and with that, we'll end our webinar.
Thank you.
Thank you. Nice to see you all. Thank you.
Absolutely.
Thank you both. We appreciate it.